Greetings, everyone. This is Eric Glazer, and welcome back to Bright Spots in Healthcare, produced by Shared Purpose Connect. We bring leaders together to not only inform you, our audience, but also unearth bright spots, successes at health plans, hospitals, and other healthcare organizations around the land. Our goal is to identify as many bright spots as possible so that you can determine if the ideas shared during this episode can be applied at your organization. We believe this approach of finding a bright spot and cloning it is the most effective way to improve healthcare in our lifetime. If you want to gain access to incredible experts across the country each week, subscribe to Bright Spots in Healthcare. Go to wherever you're listening right now or YouTube, type in Bright Spots in Healthcare, click subscribe. Each week you'll get an episode dropped into your device. Use those ideas to forward your thinking, inspire you at your organization to make a positive change to help consumers everywhere. All right, we have a really cool episode today for you. We're going to be talking about storytelling to build medical trust and how Boston Medical Center is crushing outcomes via trust and empathy. We have two very special guests here to help us learn and gain great ideas and insights. The first is Cheryl Harding. She is a patient and a community advocate. She is the founder of From Roots to Wings and a community leader here in Boston. She continues to be a strong voice for the underserved and underrepresented to ensure that everyone gets information, services, and opportunities. A great quote that I have to take from you, Cheryl, right away, because I love it so much. See me, hear me, and trust me, because all the books in the world can't tell you what my body is feeling or what I'm going through. And that's going to be an underlying theme for today's episode. So Cheryl, welcome to the show.
Thank you.
And she is joined by Dr. Katherine Gergen Barnett. She is a family medicine doc and also the vice chair of primary care innovation and transformation in the Department of Family of Medicine at Boston Medical Center, and also Cheryl's partner in crime in championing and building a lot of these cool initiatives that we're going to talk about today. So Dr. Gergen Barnett, Katherine, welcome to the show.
Thank you so much.
I'm going to start with you. We were talking prior to pressing record on the importance of the impact of medical mistrust. And so let's first talk about that, and then we're going to quickly get into outcomes. But what's the health impact of medical mistrust, and what maybe some of our listeners don't understand? I'm sure they all know that medical mistrust is not a good thing and probably has some cost implications, but let's talk about some of the details around it and why it's so important.
Absolutely. Thank you, first of all, Eric, for having us. Thank you for highlighting bright spots in healthcare. We know we all desperately need to hear more about the bright spots and thinking about what people are doing around the country that we can bring in, disseminate. So I think probably a lot of your listeners, similar to what you just said, know that medical mistrust is hugely impactful. I think that knowing that in terms of how medical mistrust feels versus the health outcomes in our communities is pretty different. So I think that the pandemic really highlighted some of the disparities. I think a lot of people thought, it was a pandemic, it was access. But what we know is that medical mistrust played a role in some of the outcomes that we have seen. And it goes way further back, obviously, than the pandemic. So we know that in communities where people don't trust healthcare systems, they are less likely to access care. So not just about access, but actually because of trust issues, they're less likely to keep follow-up appointments. They're less likely to take medications, and they're much more likely to have chronic conditions that are untreated, which leads to obviously differences in mortality. Here in Boston alone, when we see Back Bay versus Roxbury, which are just 2 miles apart, we see 23 years of health expectancy difference. And so, it obviously Boston's not alone, but I think it's really important to highlight that because we're sort of seen as this health mecca where we have hospitals everywhere. everywhere. So again, part of it is very much the way our health system is set up in terms of inequitable access. But when you look at a state like Massachusetts, where coverage is broad and we have so many institutions for healthcare delivery, the fact that we have such a huge disparity in gaps for health outcomes is really important to look at, and trust is at the center of that.
And just so people not from the area can understand, Roxbury and the Back Bay are 2 miles, 2.5, 3 miles.
2 miles apart. And, Cheryl and I could draw a little map for you, but when you're looking at Back Bay, it's predominantly white, and you're looking at Roxbury, it's predominantly Black. There's a long history of, redlining in our city and many, many other cities. But just the health outcomes of 2 miles apart, and looking at race in terms of also people's historical experience of health systems and mistreatment is radically important in terms of thinking about how do we deliver a better future.
Great. So this is what we're going to do just for our listeners. We're going to now dive into, we're going to talk a little bit about the outcomes from BMC, and then we're going to get into the hows and hear from Cheryl from her perspective, representing the community and patients everywhere. And then we'll build into a roadmap. So you should walk away from this episode with understanding what is working and what's not through this initiative that you're going to learn more about, and then maybe even a blueprint for what you could do at your organization. So let's quickly get into the progress you're seeing. Boston is known for having a lot of hospitals. For those unfamiliar with the area, Boston Medical Center is right there, sort of leaning towards Roxbury, but certainly between Back Bay and Roxbury, as Katherine had just mentioned. Tell me a little bit about some of the initiatives and the outcomes that you are realizing already as we get started here.
Absolutely. So as you just shared, Boston Medical Center is really right in the heart of it. We know from reporting that Black patients are 3 times more likely to come to Boston Medical Center than any other healthcare system in Boston. And, we really in 2021 started to do a very deep dive in looking at what our healthcare disparities were in our very own backyard. It's one thing to say you're a safety net hospital. It's another thing to say, what are we doing, positive or negative? And out of that was born something called the Health Equity Accelerator, which this project is connected to as well, really saying, what are the outcomes, particularly thinking about maternal child mortality, cancer outcomes, and how can we engage patient voice to start to change some of these outcomes? So for instance, as a hospital system, we've made huge strides in terms of maternal outcomes. So what we know is that high blood pressure, for instance, in our pregnant patients and patients who have just delivered is much higher at Boston Medical Center than many other places. Our readmission rates were extremely high, in part because women didn't have access to a blood pressure cuff and were coming back with all kinds of consequences. So we said, what do you need and how do we change it? So as a healthcare system, we've already had 19% reduction in readmissions for women postpartum. We've had much better rates of child outcome in terms of higher frequency to get to C-sections when women have needed it. But as a really thinking about what is the role of trust in kind of bridging some of these gaps, this is the role this curriculum played. And I know we'll talk about the nuts and bolts about it, but Cheryl and myself and many others have worked together to say, how do we actually bridge some of the gaps and build trust and bring people together? In terms of outcomes for that, we know that our curriculum is actually helping physicians and physicians in training already have a greater sense of how do they cede control. In other words, how do they give the control back to the patient? Because we know that's key in terms of some of this work. And patients, as a result of this curriculum, saying, I know how to take my power back, and I know how to advocate for myself. So already seeing huge outcomes from some of the work that we're doing in the community on medical mistrust.
That's great. So I want to bring in Cheryl now. And just the program we're alluding to, and keep me honest, both of you, it's called Storytelling to Build Medical Trust. It's jointly led by Boston Medical Center, an organization called Everyday Boston, and the BLAC Project, in partnership with the Transformational Prison Project. So it's and a couple other organizations, right? We Got Us and Vision Production. So it's a big joint venture that was funded by Boston University
and actually, really importantly, so initially funded by Boston University, and then NIH is funding it. So NIH actually has a whole community engagement arm. So we've had several years, 2 years of NIH funding, and we just garnered support for 4 more years of NIH SEAL funding. So this is a really critical part of what's happening nationally at this point.
Mm-hmm. Let's get into the fun stuff now. That is great. Yeah. Cheryl, now the stage is set. Let's bring you on now. And could you speak from your perspective on the role that trust plays in establishing a partnership between the providers and the community? And then I'll probably have some quick follow-ups as well.
Trust is everything between the community and the providers. And it's almost like if you take this blank white piece of paper and you say, okay, draw me some stick figures on it, and then dress these stick figures the way that you think that they should be dressed. And then these people begin to put clothes, thoughts, ideas onto the stick people. It's the same way with building trust within the medical profession. When me, as a Black woman, goes in before a medical provider, the first thing they look at is this elderly Black woman. They look at someone that's on Medicare, someone that has United Health, which I pay extremely a lot of money for every month. And they look at the fact that my zip code is 02124. So once they do that, then they say to me, Cheryl, how are you? I tell them how I feel. They're not looking at me. They're on the computer. They're asking me questions that have nothing to do with what it is that I've said. And so by the time I leave, I've not been seen. I've not been heard. I don't trust the individual because they didn't engage in me in any way. They really didn't ask me about my medical history. There's a form that you fill out when you first enter a doctor's office, and it's, does your family have this family? But they never once look at it or go back to it. And then next thing you know, I'm getting a prescription. So I'm dissatisfied walking out. Never mind the fact that evidently I didn't meet their expectations of what a patient was supposed to be, because I'm asking questions and I want to know, well, what's the next step? And why did this happen? And there's no, oh, you'll be okay, dear. You know, this is a prescription for you, and that's good. On the flip side of that, you get a doctor who, as soon as you comes in, number one, makes you feel like not only he's glad to have you there, but he's making you feel comfortable enough that you want to be there. So then you...
I was going to say, well, how does what's the difference between those two providers? And the zip code you just rattled off is one of Roxbury, which hopefully people assumed. So how do the providers then, Cheryl, establish that trust with the community? How does that one doctor that you're giving the example of versus the first one, like what's the difference there?
The difference is that the second doctor does not really look at that chart good. And 02124 is Dorchester, and not a pretty shabby neighborhood either. So, you know, that even brings it up a notch. But the second doctor is going to look at me, and he's going to see me, and he's going to talk directly to me. He's not going to look at the computer. He's going to ask me about my family history. But more importantly, he's going to ask me, how can I help you today?
That's great. And from Katherine, from your perspective, like what are some of the challenges that you and your fellow providers face in effectively connecting with the community? And sort of from your perspective, how are doctors approaching building a better, more trustful relationship with the community? And how would provider leaders listening think about applying that at the organization?
Yeah, such a great question. Cheryl, I love the analogy of the stick figures, and thank you for sharing that. I think first of all, anybody who has ever visited a doctor, or is anybody who's, been in the profession of any kind of healthcare knows that there's a ton of barriers to building trust. The first is the way that the system is set up. We have 20 minutes per visit. I'm talking about primary care, but most all specialties have that. And you've got a computer, right? Obviously, there's talk of AI helping us with some of this in terms of transcription, but a lot of us aren't there yet. The way in which a room is set up, it's actually, obviously, many of us have backs to a patient needing to get things in. We have more and more metrics that we're responsible for. So at Boston Medical Center, we've calculated we're responsible for 63 metrics for patients to, meet different payers and keep accountable. And then on top of that, we have a system that's trained folks to be very top down, to be very prescriptive, to be, we're the experts, and the folks coming to get care are not the experts, right? And then, your question is how do you flip that? I think part of it is just raising awareness, right? And calling out, okay, we need to actually do some deep examination and acknowledge the ways in which medicine has historically built mistrust and worked to, build those bridges. So A, just acknowledging it. B, it's not enough to talk about social determinants of health. I think those are really important things, to talk about. Where is somebody's zip code? What's their housing situation? How much do they have to eat? But how do you actually create relationships? And I know we're going to talk about it in a little bit, built on curiosity and connection, where you can actually start to have a human relationship with somebody. Part of that is you can actually do it in 20 minutes, but you need to be asking different questions. You cannot assume when a patient comes in the room that you know exactly what they're there for, right? You start with a sense of curiosity. But frankly, part of it is systems need to be measuring the ways in which they're building trust and they're engaging patients. And we're doing that at Boston Medical Center. We're starting to say patient experience is about trust and how we build trust. And we're asking patients, do you feel like you trust your healthcare provider? Did your healthcare provider do things to earn your trust? And getting questions around that. And the number one thing that patients will say, if you're asking them, what do you need to build your trust, is listen to me.
So let me jump in and ask Cheryl to come in here. So Cheryl, you walk into an exam room or a clinic, what are the couple of initial signals that embrace you to that provider and allow you to say, okay, this is someone who I could believe in, just so we could understand a little bit at a very tactical level what that experience is when it's a positive one?
I think that everything that Katherine said is so true. But the thing that she said that really means the most to me is the humanity to it, because that's what makes me say, okay, there's not a power structure that's going on right here. That this is someone that's going to listen to me and someone that's going to respect what it is that I'm saying. But number one, they're seeing me as a human. If you're a provider and you come in and the first thing you do is to sit down and start on the computer and not even really acknowledge my presence in the room, not even really introduce yourself, it's hi, and then they sit down. And
okay, so those are two extremes. So I want to get even more specific.
They are.
Yeah, so you come in, I'm going to make myself a doctor, Sorry, Catherine, but I just accelerated.
Very impressive.
You.
And as a middle-aged white male, and I'm your doctor, Cheryl, and you're walking into my clinic, and I'm sitting down and I'm not at my computer. I'm looking at you. What are the first things that have to come out of my mouth to allow you to realize, as a white male doctor talking to a Black woman on Medicare, that what are the things that I have to do and say to build a relationship with you initially that could be very productive and positive?
You have to, first of all, look at me. You have to introduce yourself to me, and you have to ask me how I feel. Because the bottom line for me is that, number one, it would be nice if, you hadn't been waiting for a doctor in this room, closed up with this equipment around you before this doctor comes in. So it's not that the doctor is sitting there and he's ready, he's waiting for you. The doctor comes in, you can tell at times that he's rushed, he needs to calm down. He needs to actually see me as a person that's sitting in front of him. He needs to understand that what I'm saying has value, because I know what it is I feel. I know my history, and he needs to take that into accountability. I know 20 minutes isn't a long time, but I've seen doctors do it in less than 20 minutes, where I've walked away and I have felt like $1 million and said I would trust them. I have had doctors, by the way, they interacted and dismissed me from their very presence in that room, that have given me prescriptions that I haven't even filled, because I had no idea what they were for. And
so those opening 30 to 90 seconds, super critical.
That's right.
Super critical in establishing a relationship. I'm wondering, so Katherine, you alluded to curiosity earlier, and I have I think used the word storytelling at least once as in reference to your initiatives, the two of you. How can providers cultivate curiosity amongst their organization and their team members, and to better understand the needs of their community, but also how are we leveraging storytelling to build that relationship with the community?
Yeah. So first of all, curiosity is a muscle, and one that needs to be practiced. What we have found, and when we looked at how do you actually do some curriculum with medical students and community members, and now, other folks in healthcare, we saw that there's a lot of good literature out there, but it usually is either working on the healthcare side or working on the patient side and not bringing folks together. So the first thing you need to do in terms of training people to be talking about, what it means to be listening to stories and being curious about one another, again, because it's a muscle, you actually need to work on it through your training, is you need to bring people together to learn how to listen to each other's stories, but also how to be curious about another human being. So one of the actual projects that we do, or pieces of the curriculum, we put a picture up of somebody and we say, give it to the group, say, tell the story about this person. It's exactly what Cheryl's saying. Write the story, look at this person's picture and just become curious, write the story of what you think. And then what's the actual story behind this person, right? So part of it is reminding yourself that you think that especially in healthcare, we think we know what's happening. We walk into a room, we see on a chart, diabetes, hypertension, housing insecurity, cancer, and we think we know this person. You actually don't know that person at all. You know just a list of diagnoses. So how do you step into a room and say, tell me your story, right? How do you get curious about a person? How do you listen to them with a new perspective? And the same thing is true for community members and patients. How do they get curious about what's happening for them, right? How do they start to advocate for themselves in, it really shouldn't be their job, by the way, to advocate for themselves, right? But how do they get curious about ways in which they can engage with the healthcare system, or when the healthcare system isn't meeting their needs, as Cheryl has an amazing story, gets curious about it and says, you know what, this isn't working for me. Like waking up to saying, this is my body. I know my body, and I'm actually the expert in it. And if you're not listening to me, then I'm going to find somebody else. So it's really a two-way street, right?
Wait, can I just for a minute? And I know about, but I think that that's my biggest issue. The doctors are not curious about me and me as a Black woman. I mean, I don't want to let this whole thing about race just go like if this just happens to everybody, because it doesn't just happen to everybody. It happens to somebody that looks like me, somebody that talks like me, somebody that lives where I live. But more importantly, I don't think that it's on me necessarily as the patient to have to say to this provider, let me be curious about you. Let me find out who you are. I think that the oath you took is to do no harm and come and help me. So you should really be curious to go beyond what you're seeing to find out what my needs are and how you can really help me. So I don't think that this is at this point and at this time in our history, I don't think it is a shared responsibility. I think that's on the providers to actually look at everybody as an individual, someone that has a heart that beats, that maybe there's something wrong with it, but because they're diabetic and they smoke, you don't really deserve too much of my attention because you're doing yourself some harm. Well, you don't know the stresses of my life. You don't even know the genetics of my life. It may be predisposed. So I mean, that's all.
So, Cheryl, could you provide some guidance? So, I'm really, as a podcast producer, the more curious I am, and the more I grow my curiosity skill, the better podcast host I am. And so, I've begun to study curiosity and the skill of it a little bit. And what I'm curious, from your perspective, if you were running a medical school class for providers right now, and you're curious, she is. That's what,
yeah.
That's right. Now, but you're in
already the professor.
You're in Bright Spots University right now. So if you were going to guide providers on, because curiosity is all about asking questions. And it's asking the right questions. And so I'm curious on what are sort of two or three, how are you feeling today is obviously one that comes to mind. But Cheryl, what are some other questions that nurses and medical assistants and physicians should have, at the tip of their tongue when they walk into an exam room? What are some other questions that would embrace them to you?
How's your day going? How's your day going? Because what they don't realize is that by the time a patient gets before them, they are so frazzled. They have hurried, they have missed a bus, they have been stuck in traffic, blah, 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 to the point where when they get there, everything that they were feeling physically, they're just overexhausted with it. So I need that doctor to just take a minute, say, how's your day going?
Okay, so here's so this is great, because we always just in everyday life, hey, how's it going? And I'm always,
they don't listen. They don't listen.
Right. So this is right, exactly. So and this happens not just in the medical setting. This doesn't happen between different races. This happens all the time. Oh, it's actually not going great. So what's the next question that person in that room has to ask you to make sure that that they listened?
How can I help you feel better? Simple as that. How can I help you feel better? Because all the charts, all the histories you have, that may not be there what I'm presenting for. And just take a minute to hear a story, because sometimes we just need to tell the story. Curiosity is one thing, but responding to that curiosity is a completely different thing. If I say to you, well, my head hurts today, and you say, oh, I see you have a history of migraines, you didn't hear what I said. Because I didn't say my head hurt for the last 5 days. I said my head hurt today. So what's making my head hurt today? And how can you help me?
Can we talk about that, Cheryl, for a moment, about storytelling? So when you're talking about storytelling to build trust, how are you guys thinking about storytelling, and how are you applying it in that way? So could you explain that a little bit for everyone?
Storytelling is amazing because through the short space of a story, you get to, number one, know someone, you get to feel someone, and you get to share a space of humanity. Because when you're telling a story, especially about yourself, all your guards are down.
So are you suggesting the provider is prompting the patient to tell the story, or are you suggesting that the provider should share a story about them that would relate back to the patient? How are you applying it?
I think that goes two ways, and I have had it go both ways. But I don't necessarily think that the provider needs to be sharing a story. What the provider needs to do is engage and listen to the story that's being told. It doesn't have to be this long drawn. I mean, we know when someone's paying attention to us. That's just us as people. So you wouldn't have somebody that would just be going on and on and on about the story that really doesn't relate to what it is they're there, or see a way for it to connect to the provider. But I think that the provider's responsibility is to listen, and with not only just curiosity, but with a willingness to sort of understand how that correlates with how their next step is going to be to treat that person to make them feel better.
Okay. So it sounds.
Can I add one thing?
Yeah, I want to make sure I'm clear. I want to make sure that I'm absorbing this in the right way. And Katherine, I was going to ask you to jump right in on this. So are you suggesting storytelling to build trust? It's really, tell me if I'm misinterpreting this, it's really listening to storytelling to build trust, being curious about the story to build trust. Is that what I'm gathering here?
And we're talking about in the medical field, by medical providers,
No, of course.
that they need to be a little more curious about the person in front of them than the chart that they're seeing on the computer.
So Katherine, did I get that right too?
First of all, I just want to say, Cheryl, I just want to say thank you for your work and your words, and again, just emphasizing that it's really on the providers to be curious, and it's not just, as you said so eloquently, the listening, but also part of the work that we do and that Cheryl's really helping lead is about how do you ask better questions? How do you ask questions that are open-ended questions and not yes, no, one-word questions? And I think, again, because we are so trained to get to the bottom of things in medicine, and we're always so rushed, we don't actually sometimes want the real answer, right? We'll ask a question without really, to Cheryl's point, actually really asking a question at all. We're just hoping for a yes, no. Oh, so you have a headache? Well, it looks like you have a history of migraines. Is that right? Like, that's a yes, no, right?
Yeah.
Versus saying, tell me about the headache. How can I help you with it? How's your day? Like all of those things which incur stories. How do we learn how to ask more open-ended questions in medicine, right? So coming back to this real human aspect of getting stories from one another. We are storytelling creatures, but we have shut the doors in medicine to hear people's stories.
So let's bring in, we'll put both of your professor hats in. We'll bring back in Professor Harding, and we'll also have Professor and Dr. Gergen Barnett talk. How can we outline a roadmap for folks listening across the country, far away from the 617, what are some key components, Professor Harding, and what should be built into a curiosity strategy, a trust strategy for an organization so that it could be implemented? So I don't want to talk about the individual provider anymore.
Mhm.
I want to talk about like how as a hospital X, or even a health plan X for that matter, can start building a culture and a strategy around curiosity and building trust.
I think for me that institutions, people should stop being the great Wizard of Oz, and they should stop mixing up a whole bunch of things and thoughts and ideas behind this great big screen, and actually pull back that screen, let that person sit there and actually understand what the process is, what your role is, and what you can do that's going to help them while they're coming to you, whether it's for health care plan, what are the best benefits that I can get from you, according to, of course, the money you have to spend on a health plan, whether it's a doctor. Am I the right one? Are you the right one? Because I know who you are. I know that you're a doctor that treats my head and not my heart. So am I with the right doctor? That's going to build trust. Number 3, I think for me, is that when you interface with a provider or an organization or an agency, that you don't feel like you're invisible to begin with, because that's a hard road to try and overcome. It's like the little kid in the classroom that, feels that the teacher never, ever calls on them. So you're always raising your hand, pick me, pick me, pick me. That's how it gets to feel sometimes. So I want not to be invisible. And that's how providers, organizations, agencies can help me. Just see me.
Okay, keep me honest here. So I took some notes. I don't think I captured it in exactly the order you said it, but tell me if this is correct. First, make sure you have a conversation. And within that conversation, ask the right questions to demonstrate to the consumer that you actually do care. And then within that conversation, ensure that the person coming to you understands your role in helping them and understands their role in helping themselves. And then the last thing, although you didn't say this last, but I just was scribbling here, is educate the consumer, the patient, on what is going to happen next and why, and educate them on what benefits they have and why. And even though you didn't say this, but in a way that is sort of clear and simple versus some of the complex words we tend to use in healthcare. Did I miss anything, or did I overstate anything there?
I don't think that you missed anything. But one thing I do want to point out is that we don't expect the providers to care immediately. They have to build trust too. So this is a two-way street, the same way where they don't know me and I don't know them. But hopefully through a meaningful relationship of me getting better and them feeling good about what they're doing to help me get better, that trust will be built. You don't just meet somebody on the street and say, oh, I'm going to trust them and go into their house for a cup of coffee. You want to know whether or not they wash their dishes good, whether or not their house is clean. You want to know something about them. So, and that's through a building of a relationship. I might not even care about the coffee. I may just be more interested in knowing who that person is. Same thing with a provider, an agency. They may not want whatever it is that I'm there for, or they may not want a relationship with me, but through a meaning and caring dialogue, that's how we build a relationship together.
So I love it. And Katherine, from your perspective, from the BMC, Boston Medical Center perspective, and the physician perspective, what are some lessons you've learned in the process of implementing this program that maybe if you had to do it all over again, you may do a little bit differently? Like what challenges, or I dare say missteps, can we alert our audience to so that maybe they're not repeated?
Yeah. So I actually think this has been an incredible kind of the building this curriculum has been a microcosm for what it means to do this work. So first of all, bring community voice and community experts in first. Have them drive the work with you in connection with you. I think, we really initially heard community voice, did restorative justice, did storytelling, and then built a curriculum on medical expertise and actually brought it back out to the community. And folks said, that's not the curriculum we want. That's not going to work. So we had to break it all down and rebuild the curriculum with community input. So as a system, as a healthcare system, and as educators, you have to put the voice of the experts from the community in the center of everything you're doing and do it with great humility. Because as Cheryl said, we are not the experts on somebody's body. The patient, the individual is the expert on their own lived experience and their own body. So then, and their own lives. So how do you bring that voice in? And so systems need to build it through, advisory boards, but advisory boards that really make a difference, that are not token, right? You can't just have patient advisory boards. And in our case, we also have a youth advisory boards. Those voices can't just be token about what they think. Their voices actually need to drive the change. And the same thing is true in terms of how do you change curriculum to build trust? It can't just be nice, but not necessary. Systems need to be built on this being a necessary way of changing. And again, patients need to be at the center of that. And then finally, I'll say, get out of the hospital, get out of the healthcare system to do this work. We know that's not where people live, pray, play. You need to be in the community where folks are living their lives to truly understand humans. So medical education, the work we need to do, needs to also happen in the community and not just inside the walls of healthcare institutions.
So Cheryl, I love that, and I'm going to summarize it for everyone in a moment. Cheryl, but I'm going to ask you the same question, but from the community perspective. So if you were going to do this all over again, if I could give you a time machine, and you were going to start building this program all over again in partnership with a hospital, I've transplanted you to another city. And if you had, what are some things from your perspective, from the community perspective, that you would do differently, that maybe there was a misstep?
I think that I would bring the providers and the community together outside of a hospital setting.
So that's something you guys didn't do initially, and you eventually you do it sooner. Okay.
Correct. No. Yeah. And not in the medical profession setting. We would be in a playground, in a community hall. And I would also see where the intergeneration was. I would also bring in some younger people because they've had stories that they've had to tell and had no one to listen because they were young, about how they feel like they haven't been heard, listened, or seen. I would actually have the dialogue about what best practices look like. And coming from everybody's perspective, from the patient's perspective, from the provider's perspective, I would actually look to, for me personally, Cheryl, I would want to know from a doctor, what made you want to be a provider? Is it because your daddy was one, your granddad? Is it because this is the family business? Or is there something about human beings that you can provide care to help change the society so that they live healthier, longer, and richer lives mentally and emotionally? So I think that that's how I would begin it all over again, just bringing folks together and saying, who are you? What do you need? It's almost like a flea market swap. What you got? What I got? Let's see how we make this thing work together. It's just that simple.
I love it. All right, let me summarize what I think I heard, and you guys could keep me honest. So, as the two professors, so first, bring the community voice in from the start. Don't wait for that. Have them drive the work. If you're going to create a consumer/patient advisory board, make sure they're actually empowered to make changes and influence the program. Also, get out of the hospital to do the work. Start with meeting together in a non-medical setting in the community where you could bring providers and community members together, and make sure that the community is represented by not only different genders and race, but also different generations. Don't just have the elderly, who are often the most frequent flyers, but have the youth. Have the youth too. And then in the flea market kind of theme, I'm going to use flea market here. I love that. Make sure that the format or the environment for these meetings are where we are sharing best practices. What does best practices look like from a community perspective, the patient perspective, but also in a probably a very I don't want to say just condescending way, what best practices look like from a health standpoint, from the medical expert standpoint. And then something else, some other nugget that you just actually shared with us, Cheryl, that I think might have even been, is best used in the clinic. So I'm going to just quickly, now that we have the strategy there, but I want to make sure I mention it so that you could grade me if I capture it right, is, when you're building trust in the clinic, and, certainly understanding, like, how are you doing? How can I make your day better? How can I make things better? These were all great questions that you shared with us. But maybe sharing, like, why I became a doctor is a good way of building trust and building a relationship with you. What made me want to become a physician, a nurse, or be in the medical field? So I captured. Did I miss anything?
I think you got it from my perspective. What about you, Katherine?
Did a great job listening, Eric.
This is so great, and I know we're sort of out of time right here. I didn't know, maybe before we sign off here, I'll start with you, Katherine. Is any final thoughts or advice, and certainly where could they find more information about the program? And then Cheryl, I'll end with you and ask you the same question.
Yeah, so we can drop the link to our program in your show notes, and you can actually watch some videos of individuals telling their stories. We have a lot there. We have more about our curriculum. And
also, and I can say it to everyone, storytelling to build medical trust. And it's storiesformedicaltrust.org. We'll definitely put the URL in the show description, but storiesformedicaltrust.org. Okay.
Yes, absolutely. And also just, keep your eye out, because we've got 4 more years of building this work together. We're really excited about our future work. And I just want to, end with something that Cheryl said, call it out again. Trust is everything. Don't undermine it. Don't undersell it. Don't overlook it. It is at the core of what we need to be doing in healthcare.
Cheryl, any final pieces of advice for everyone listening?
I do. I want to just say that this came about, the medical trust, building medical trust, because of all of the medical mistrust. So go on everydayboston.org and listen to some of the stories of the ways that folks have felt like they have been truly devalued by the medical profession and didn't get what it was that they needed. And thank God for Katherine and those at the BMC that said, okay, we see this, we hear this, what can we do about it? How do we build it? How do we get out information? How do we get these stories out? How do we go about trying to correct some of the ways that have prevented folks from getting the kind of medical care and attention that they not only need, but they truly deserve, and with respect. So go to everydayboston.org, read some of those stories, and then follow us up on the website.
Love it. I really appreciate both of you trusting me with the time that you guys spent with me and being on this show. I know there's other outlets you could be talking about this, so thank you for that. My message to everyone listening is, when a problem may look hopelessly complex Rather than looking for this large, massive cupboard to fill a large, massive hole, use the strategy of looking for bright spots, things that are working well among all the chaos. And these tactics often generate programs and an entire solution strategy to your toughest challenges, like building trust with consumers. So take some of these ideas today and think about it maybe as core components to a new strategy that could change the paradigm for your organization. We hope you use the Bright Spot Share today to inspire your thinking. Copy a couple of these bright spots, clone them at your organization. We provide this show for you. And remember, this is your Bright Spots in Healthcare podcast.